Fantastic. Good morning, New York City time, and welcome to our Thyroid International Recommendations Online, or multidisciplinary seminars session. These are the ones that we have monthly or thereabouts, where we bring together a panel of real clinical experts and radiologists and nuclear medicine doctors to talk through real-world cases. This is one of my favorite things to do each month, as I get to listen to experts sort of think through cases about how we're doing it. Today our focus is going to be pediatric thyroid cancer, and we really have a world's expert panelist here to help us walk through some really exciting cases. I'll ask each of them just to quickly introduce themselves so we know who you are and where you're from. Dr. Wasserman?
Thanks, Mike. Jonathan Wasserman, pediatric endocrinologist from Sick Kids in Toronto.
Perfect. Dr. Kazahaya?
Yeah, this is Ken Kazahaya from Children's Hospital Philadelphia. I'm a pediatric otolaryngologist, head and neck surgeon.
Fantastic. Dr. Frates?
Mary Frates. I'm an radiologist with a specialty of ultrasound at Brigham and Women's Hospital in Boston.
Fantastic. Dr. Faquin?
Bill Faquin. I'm a head neck surgical pathologist and cytopathologist in Mass General Hospital.
Thanks, Bill. Dr. Castellanos?
Good morning. I'm Lucy Castellanos. I'm an MD Anderson and a pediatric endocrinologist.
Fantastic. Dr. Wong?
Hello, Wong. I'm a nuclear medicine physician at University of Michigan.
That's fantastic. And Dr. Bauer, you get to multitask, introduce yourself, and bring your slides up all at the same time. It's the first challenge of the morning.
All right. I'm Andy Bauer, a pediatric endocrinologist from the Children's Hospital of Philadelphia. And there we go. Did I succeed?
You're good. Let's do it.
All right. Good morning, everybody. So we have three cases. If we make it through all three, that's our goal, but it's not a requirement. So please send questions if you have them. Mike is looking at our chats, and we'll try to go through the questions on the chat. But hopefully this is a fun discussion and all of us learn something from each other. So our first patient is a 15-year-old who had a 2-week history of non-painful neck swelling, also associated with some anxiousness and increased resting heart rate, with occasional palpitations. Labs were drawn, revealed an undetectable TSH and a elevated T4 level, and a point of care ultrasound was performed. And here we have the ultrasound.
So my turn?
Yep.
Okay, so on the ultrasound image, we've got a grayscale and a color image of the left lobe of the thyroid, and I think everyone can see outlined with the calipers. There's a large, we would call this a mostly solid lesion. It's got a few small cystic spaces, but that's less than 25% of its volume. It's got color flow, which almost every thyroid nodule has. It's not a hypervascular nodule by any means. It's quite large in size. It's 4 by 3.5 by 2.9. And so if we go ahead and use the TIRAD scoring system, we would give this 2 points for being solid. And 1 point, I would call it mostly hypoechoic. No echogenic foci, it's pretty smooth margins. So it would get a TIRAD 3. For adults, we would recommend a biopsy because of its size. Typically, the radiologist looking at the thyroid nodules will not have any information about the thyroid function. So we do not take the function of this nodule into account. For children or adults, I would recommend an FNA.
And Lucy and or Jonathan, the labs consistent with an autonomous nodule, would you do a thyroid uptake and scan? What's the next step in addition to considering an FNA?
So, I can pipe in. I think along the lines of what Mary said, not all autonomous nodules need to be biopsied in kids. If there are any suspicious features, maybe Mary, I can put her on the line to comment on the applicability of TIRADs in children, because she's had a lot of thought about that. But only if there are suspicious sonographic features. I probably would consider an uptake and scan for this patient if we're thinking about surgical intervention for the patient. And although the thyroid function tests are only marginally abnormal apart from the TSH, the T4 is normal, the T3 is only marginally elevated. So we expect this to be probably what we would call a warm nodule rather than a hot nodule. And I'd also, from the scan, want to know whether or not there's any extra thyroidal uptake, because that would inform our assessment of the underlying pathology.
I'll
So
just
one,
add, I agree with an uptake scan. We normally do this in any patient with a nodule and a suppressed TSH. It's like an automatic part of our algorithm.
And also,
I'll just toss in my thoughts about TIRADs. So, TIRADs were designed to be used in adults, and they were designed to decrease the number of unnecessary biopsies and still, excuse me, maintain a high level of diagnostic ability for aggressive cancers, right? So we're trying to get the aggressive cancers in adults, and we're trying to avoid biopsying the benign cancers in adults because we know what the natural history of the disease is in adults. We also know that that's different for children, and what our group has suggested from the Brigham, and which seems to be sort of where people are falling in line, is to use the same descriptive categories and categorize the same way, but shift the recommendation sizes over one category. So the numbers that we would use at TR4 in an adult, we would move those numbers over to TR3 in kids, and we would take the numbers from 3 and move them to TR2 for children. So you just are upping the number of nodules that you'll biopsy, but we know that's more important in children than it is in, say, a 72-year-old, right? But in this case, the nodule is so big that it meets criteria, because the other thing that we've shown when we looked at a large series of nodules in children at the Brigham is that the nodules that are over 4 centimeters can fool you. And when they get this big, they probably actually need to come out. An FNA may not even be sufficient to tell you what the nodule is.
Just one thing to add to what Mary said, and I know Kake wanted to speak as well, but I think buried in a lot of important stuff that she mentioned was needing to know the criteria of TIRADs. And for us in children in particular, just getting a referral with this is a TIRADS 4 nodule isn't sufficient. I'd like to know, why was it a TIRADS 4 nodule, and what were the features that made it TIRADS 4 or 5? So that's an important part of the referral for me.
I was just going to mention that in Michigan, our pediatric endocrinologist would look at the TSH being suppressed and order a thyroid scan and uptake. It looks like a T3 thyrotoxicosis, which has been described with autonomous nodules. And then in our literature, once you confirm it's a hot nodule, then it's recommended not to biopsy them because they'll come back as follicular lesions. Now, there are rare case reports of hot nodules that end up being thyroid cancer, but they're supposed to be exceedingly rare. So I think there's individual characteristics of the patients that have to come into play here.
So that's a perfect lead in, which I think we kind of already talked about the indication and what would be the next step. And this is a proposed near final. Jonathan is co-chair with me with Stephen Wagesback on our updated ATA pediatric guidelines. So this is the tentative draft, as you can see written here, not final version. And if we try to follow through, if an uptake and scan was performed and was consistent with an autonomous nodule, whether it was warm or hot, there is a recommendation that an FNA is not necessary. And then we can go into what the right treatment would be. Would you consider ablation or thyroidectomy? But in this particular patient, for this particular sonographic features of this nodule, is the uptake and scan going to change the next step of the process? It can be a rhetorical question, or if someone wants to answer that, because irrespective, even if you don't do the FNA, you do the uptake and scan, it's a solid 4 centimeter lesion. Are you going to leave it, or are you going to recommend lobectomy? Any takers
It
on the
depends.
question?
You know, what Kit was saying is quite valid. If you're thinking about the risk of malignancy going into it, it's very low. This is a 15-year-old who's got mild thyrotoxicosis but quite symptomatic, and it's a big lesion. So if the conversation is, I'm going to want this out regardless, then you can go straight ahead. But I don't think this is a slam dunk. This needs to be treated just based on the existing data. We need to have a conversation with the patient and see what the priorities are.
Even if you're going to surgery, what if this was Graves' disease and a big cold nodule, right? I mean, that would probably change your surgery if you knew it was a Graves', right? Or change the way you thought about it.
I guess it depends why it was a cold nodule, right? Is it a cystic lesion or partially cystic?
Right. But the nodule's coming out, right? I mean, we do the same.
Right. No, to your
This
point,
is
right.
the nodule's coming out. The point is, what do you do with the contralateral lobe, right? If it's Graves, we may do a
Right.
total thyroidectomy. If it's just that hot nodule, then we're just talking about one side. So for me, it's the discussion about what to do with that contralateral lobe, not the nodule that I'm looking at.
All right. Any other comments about that? If not, we'll move forward with what happened clinically. And just a quick note, which will be changed in our guidelines, that the 2015 guidelines mentioned a much higher rate for malignancy for autonomous nodules in pediatrics. The data that's since been published, again, makes it more consistent with adult, about 5 to 6% risk for malignancy up front, and then you look at the sonographic features to help guide whether if it's a higher potential risk for malignancy and whether an FNA would be beneficial. So we talked about lobectomy versus ablation. We did not move forward, which is not a common path for us. We usually do uptake and scan, but because this was a solid 4 centimeter lesion that had a suppressed TSH and we knew we were moving to some procedure leaning towards lobectomy, we decided not to go through and do the uptake and scan. The family was interested in an FNA, which we agreed was reasonable. And we also then placed the patient on methimazole. So for the endocrinologist, Lucy and Jonathan, is that beneficial? What dosing do you consider? And what's the purpose of methimazole, if there is one, for patients with autonomous nodules?
Well, I would love to hear from all of you about this because normally I would use a beta blocker if the patient's symptomatic, especially helpful for tachycardia and high blood pressure, which it sounds like he was having some of these symptoms. Methimazole I consider more for my Graves patients, so checking the TSI in that kind of setting and trying it out. But I'm curious your experience with methimazole and the nodules.
Jonathan, any comments?
I think it depends also. I agree with Lucy, actually. I probably would have started with a beta blocker.
Sure.
Depends on the time course. I would think of methimazole largely as a bridge or the beta blocker to therapy. I tend not to use medical therapy for long-term treatment of autonomous nodules, assuming that the thyroid receptor antibody was negative, to Michael's point. So it's reasonable to use it, but only as a temporizing measure.
Right. Yeah, I think that was the thought. The symptoms and a beta blocker could have been used. And also, if it's prolonged, to Jonathan's point, potentially, theoretically, you can protect the other lobe from being overly suppressed and maybe increase the likelihood that function of the contralateral lobe would be maintained after therapy of the autonomous nodule. So that was the thought process besides that. So an FNA was performed, and Bill, what do you think?
Sure. So we have this and the next slide as well, showing crowded groups of follicular cells. This is the alcohol fixed preparation. I'd point out that there's no colloid in the background, which together with these crowded follicular groups would be placed into the Bethesda category for cytology of follicular neoplasm. And this has a low to intermediate risk of malignancy, all things being equal. Also, I would point out that we don't see nuclear features of papillary carcinoma. The nuclei are a little bit enlarged, they're oval, but they don't look pale and grooved with inclusions. So it seems to be a follicular neoplasm. Someone mentioned we don't like to do FNAs of autonomous nodules necessarily because you can get sort of a false positive, and that's true. I cannot tell from looking at this whether it's actually a neoplasm or some kind of hyperplastic non-clonal proliferation. I can only tell you that it cytologically it looks abnormal.
Right. Thank you. So would molecular testing help if we have an indeterminate nodule?
No. Next
That
question.
shortens the discussion.
No,
If it's negative, you're going to proceed with lobectomy. If it's positive, you're going to proceed with lobectomy. Is that the point?
you may get an outlier, but often, assuming again that we're looking at an autonomous nodule, these are often either TSH receptor somatic variants or G alpha, GS alpha driven, and those don't really help me if I'm trying to ask, is this a malignant process? With the follicular neoplasm, similarly, if this turned out to be RAS driven, it's still not going to really change how I'm going to approach this. So in the unlikely event that we're looking at BRAF or fusion driven, of course it would change it. But I think the likelihood of that and the access to molecular testing in many cases for pediatric patients, to me, wouldn't justify going down that route. If it was easy to get, it was free, it was on special this week, maybe, but I don't think it's going to add much to this patient.
Just to play devil's advocate, I mean, these molecular tests are paid for by insurance, but it's a little bit academic. But what if it came back showing an inherited alteration such as Dicer1 or P10 or something like that? Would that change what you're going to do?
Funny that the pathologist is asking me that, because I think we don't need that information pre-operatively necessarily. If we're going down the road of lobectomy with Dicer1, particularly, you may see a background in the thyroid that's more characteristic of Dicer1. And we could do testing on the tumor specimen rather than on a biopsy, which will probably be, we can certainly get that in pediatric patients covered by insurance or covered by Children's Oncology Group now, and that will give us the same information. So I don't think we need that information bill going into surgery.
Yep.
And as far as I know, someone can correct me, there's certainly follicular neoplasms are common in those two syndromes, but not autonomous nodules. Is that a fair statement?
Yes.
All right, good. All right, so testing was performed. Actually, it was post-operative testing, but the patient did have an activating mutation in the TSHR receptor. So surgery performed. Anything special you have to worry about, Ken, for these types of surgeries, or are these pretty straightforward?
Yeah, typically if they're well circumscribed like this, it's relatively straightforward. The lobe is very nicely separatable from the surrounding tissues. Parathyroids are easily preserved. It doesn't look like in the ultrasound was involving the capsule. We're always a little concerned if it's closer. That if there's evidence of an extrathyroidal extension of a mass in the thyroid, but in this case, it looks pretty well smooth surfaced. Doesn't seem to be involving or extending from the capsule, so we would expect it to be relatively straightforward and easily dissectable.
And you're going to leave the isthmus?
I would actually leave it. Yeah, leave as much thyroid, not natural thyroid tissue, as I can behind in order to preserve function.
And Ken, any difference in the technique of taking the thyroid out, or any special things different in a 15-year-old than when they operate on the adults and the 25-year-olds, or it's pretty much the same thing in miniature?
Yeah, I find it in this age group it's very similar to working on an adult. If we start getting younger, there's a lot more issues like thymus, brown fat, things that are going to make it a little more difficult for you to identify the parathyroids in the central bed. But by the time they're like 15 or late teenagers, they've lost a lot of that brown fat and the thymus has regressed. So it really is a little more straightforward.
Ken, how would you approach the central neck on that side?
I would leave it. Yeah.
Based on ultrasound and cytology, no prophylactic central neck dissection.
Correct.
All right. So Ken is successful in removing
So
lesion.
everybody predicted the TSHR mutation, which is a low risk for malignancy. The tumor shown here, it's very cellular, not much colloid at all, as we expected based on the cytology. And it does have a very thick fibrous capsule, which is not a very specific finding, but it makes me a little more concerned when I'm evaluating thyroid nodules. If it's got a thick capsule, that's more characteristic of something that could potentially be carcinoma. Again, not highly indicative of that. And I think the next slide.
Bill, that one area kind of at 4 to 5 o'clock, is that FNA? Are those FNA changes, or is that just a large nodule that's lost a little bit of vascular supply? Or am I overreading that eosinophil area?
Yeah, that looks it may very well be due to FNA changes causing some fibrosis and degenerative change. Yeah, I mean, unfortunately, the surgical pathologists have to be on the lookout for things that are FNA changes, and they can even cause features that can mimic minimal capsular invasion.
Right. All right, and then higher power.
So at higher power, actually the architecture is papillary or pseudopapillary, but as shown in cytology and shown here, the nuclei are not those of papillary thyroid carcinoma. This papillary architecture is more often seen in benign nodules. But on the right-hand side, we have an area where the capsule is violated and it looks like there's tumor sort of transgressing the capsule. So based on this, there appears to be minimal capsular invasion. I was told that there was no angio invasion detected. Again, this is the kind of thing, though, where we would probably do multiple deeper levels just to make sure we're not seeing hemosiderin or other features that could suggest it's related to an FNA type of artifact.
Great.
So based on this, it's a minimally invasive follicular thyroid carcinoma.
All right. So it's a carcinoma. Should we get rid of the other side?
I think we're looking at it's a carcinoma, but just barely from a few cells going into the capsule.
That's like
carcinoma.
That's like being a little bit pregnant, right, Jonathan?
That's right.
So this is a little bit pregnant.
Yeah. No, it from what Bill showed us, it just barely meet criteria for carcinoma, and there's no angio invasion. We were told it's N0 based on the WHO. We don't have separate pathology outcomes data in children, so we rely on the WHO criteria. And we really look at the likelihood of residual or recurrent disease as a function largely of the extent of angio invasion. And if there was no vessels involved here, the likelihood of recurrent disease or distal metastases is going to be pretty low. I don't think this is an individual who would necessarily benefit from a oncologic prognosis standpoint from a completion thyroidectomy.
I would agree with that. With our minimally invasive follicular thyroid cancer patients, we do just offer surveillance. So I would reassure family that there's no evidence of angio invasion. Of course, like Bill said, we are relying on good pathology review of this.
Just one quick question. When follicular thyroid cancer in young adults is incredibly uncommon, right? It's papillaries, it's follicular variants. When we see follicular thyroid cancers or big follicular adenomas in young, we actually think about Cowden syndrome as something to sort of think about. When you guys see the follicular cancers in the young people, does that ring any bells of germline? Obviously, she had thyroid-seq, so we know she doesn't have P10, but is that something you guys think about or we should think about in these follicular cancers in young people?
You can think about it. I think it's always reasonable to think about Cowden syndrome. In kids, we will very often see other features of Cowden or P10 hamartoma tumor syndrome.
Gotcha.
More of a mouthful, but they often will have macrocephaly, which may not be apparent visually. I always do measure them and plot them. And not uncommon will have features of autistic spectrum disorder, learning disability. So and then family history. So it's reasonable to think about it. I don't necessarily send all patients for germline testing if it's solely based on the follicular histology.
So you recommend maybe I do a history and physical instead of ordering a molecular test?
Maybe.
That seems backwards, but okay, reasonable. Okay, Andy, back to you.
Dicer 1's also there, and the problem with Dicer 1 is clinically it can be lower expression, low penetrance in a family. But so LT4 replacement, just quickly to wrap this one up, would you start or would you wait?
Depends if she's symptomatic. I think she would certainly.
Say.
No one would argue that this isn't hypothyroidism that could be treated, but it tends to be transient in these patients recovering from autonomous nodules. So if they're not symptomatic, I might see if patient was willing to wait it out. But otherwise, you could treat with the expectation that you'll withdraw treatment in a few months.
Yeah. So we waited because she was asymptomatic, and you can see it does take some time for recovery. So sometimes patience is the best approach. And then, of course, confirming this is currently an active patient. So we'll probably do another one in 6 months just to confirm normal's normal. But we'll end with that, I think, and move on to our second patient, unless there's any closing comments. But I think we're ready for patient number 2.
Thank you, Andy. So this is an 11-year-old girl. She's a professional singer, recently moved to the area and established care with her PCP. During
Sorry.
this initial visit, they mentioned that they noted having this asymptomatic neck mass for more than 3 months, which the PCP did palpate in the supraclavicular area, a lymph node that was about 4 centimeters in size. So she refers to pediatric general surgery as well as endocrinology. The general surgeon does see her first. We received the notes, and they had planned on doing this excisional biopsy. So my question to Andy and Jonathan is what the role is for excisional biopsy in our patients that have thyroid nodules. I know this is a little non-specific presentation so far.
In
So
general,
excisional biopsy before imaging, is that?
So he's going to get imaging, but he already was planning on an excisional biopsy of that supraclavicular lymph node.
I could put it to the surgeons. I
One
wouldn't
thing
be
I
anxious to
caution
go to
my
surgery before the imaging.
Yeah, we typically would not recommend to do surgery before imaging, especially in a young female. If you've got a lymph node, you got to image the thyroid. You got to get an ultrasound. It just behooves you because very often you'll see a lesion in the thyroid, and then you know what the lymph node's from. Also, it gets you an idea of what the lymph node looks like, characteristics of it. Is it going to give you some microcalcifications in the lymph node? Then it's going to really point to your thyroid. But I think there. Unfortunately, we see these lymph nodes getting biopsied prior to imaging, and then it comes back as surprise, surprise, a papillary thyroid carcinoma or something else because the child wasn't properly worked up.
it violates the one incision is better than two rule, right?
I think also this is the TIRO by MD's tumor board, but there's a differential diagnosis for supraclavicular nodes, and I'd like to know what else we're dealing with.
Next slide, right, Luce?
Yes, next slide. Yes.
I don't want to get ahead, even though I did a second ago. Sorry.
Okay, so it's interesting because we have images of the neck ultrasound. Well, this is obviously a ultrasound of the thyroid gland, but I was very interested in knowing what that palpable 4 centimeter supraclavicular mass looked like as well, right? But certainly the thyroid gland, I think everybody's used to looking at these, but this is the trachea in the midline. Here's the carotid, common carotid on the right, common carotid on the left. Oh, sorry. Yeah, I'm using my pointer, thinking that it's working. Yeah. And you can see that the gland is enlarged, right? You have a thickened isthmus. You have bulging of the anterior contour of the gland on both sides instead of a smooth or even convex surface. And then the overall gland is heterogeneous, but notice particularly on the left side, all of the little speckles that are there. Yep, those are speckles, speckles, speckles. They go all the way back down, right? This is not an occasional little piece of colloid. This is a problem, and this problem is not located in a 1 centimeter little circle. They're everywhere. Yep, they go all the way over to the right side as well. So I'm very, very suspicious of papillary thyroid cancer, potentially diffuse sclerosing, and I haven't seen what that lymph node looks like, but it's got to be a MET. And the next thing that is so important when we see this is to just make sure that we do a full lymph node assessment at the time that the patient is in the department, right? If you've got to look at the central compartment, you've got to go all the way up. And in kids, you almost have to go to their ears on both sides because you do not, as we already heard, one incision is better than two, and you do not want that child to come back 6 months post-op and realize that there were 6 or 7 lymph nodes, in the back of their neck or up by their ear that got left behind at the time of the surgery. Here's the CT scan, which is the reflexive ordered study for many folks around the world. But as an ultrasound person, I would say, for the head and neck, really, you can start with an ultrasound. We are very, very good at the head and neck because it's so superficial and our resolution is so high. But as not surprisingly, you can see, again, if you just don't mind pointing out the carotid, the carotid, which is the carotid artery, and then moving laterally, the jugular vein, which is a little bit bigger. And the next step out is the abnormal lymph node, which is enhancing, right? It's a little bit whiter than the surrounding muscle or fat. And then the next white thing out is probably the subclavian vein, I would say probably. But so you have this big enhancing lymph node there. That's presumably the thing that they were feeling. But there are other enhancing lymph nodes also around the neck, yep, on the left side. And again, this is just one image through the neck. Presumably you need to go all the way down into the central compartment and again, all the way up to the ears.
Hey, Ken, let me ask you here. In adults that have this big, and we'll just assume this is papillary cancer, lots of lymph nodes, we worry about high retropharyngeal, we worry about upper mediastinum. So imaging beyond just the ultrasound, what are you sort of thinking to sort of plan your surgery instead of imaging in areas you need to worry about, Ken?
Yeah, when we see like a large gland like this with lots of lymph nodes, I do like to get cross-sectional imaging to look at the entire thyroid itself, to see if there's a retroesophageal or retropharyngeal component, especially if it does seem to be thick in the back, because that can really affect what we're going to do for dissection, and the nerves that are going to be there. The recurrent nerves are very much at risk, especially with that extension. So we really want to know what's going on back there. Also, sometimes it really can help us map the neck as well, to get that idea how many lymph nodes are high and going all the way down in the neck. We can see that and we can plan ourselves very effectively.
Does the contrast play a factor? Because you need contrast, right? If you're going to do a neck CT?
Yeah, we prefer contrast, and we don't find that to be a problem in the long run, because by the time they get done surgery, recover from surgery, and you're going to do a diagnostic scan, the iodine's washed out.
The other thing that we do, I don't know if folks in other areas do this, but for all of our children, we have a very close relationship with Boston Children's Hospital, and so the kids are operated on at Children's, even though they have their ultrasounds and their biopsies at the Brigham. So we go over to Children's Hospital and we go to the OR, and once the child is under anesthesia before the prep, right? So it's all non-sterile, but the surgeon's in the room and I'm in the room and the patient's in the position that the surgery is going to happen in. And we take another look around with the ultrasound. We go all the way up and all the way around and look and look and look, and they make notes and they know exactly what they're looking for. And because, you don't always have a cooperative patient when you're looking preoperatively, right? They're scared, they're in for a biopsy, they might be 4. Actually, the 4-year-olds are usually easier to scan than the 12-year-old girls, but there's often some drama and they don't want to lift up their head, or they're anxious and they've got their headphone. And so we actually find that immediate pre-op, right prior to the incision study is sometimes very useful for really everyone knowing what needs to come out.
Booze, okay. Are ready for next one?
Yes.
So this is still pre-op, I assume?
Yes.
Yeah. So on this preoperative chest CT, and this is a high resolution lung window, meaning you can see all the vessels going out from the mediastinum. And I don't read CTs, but my chest colleagues tell me that it's pretty obvious that there are innumerable little tiny dots. There's arrows on them in the left chest, but there's also, you can see a couple over on the right chest. Yep, there's one right there, and there might be another one way up in front of the right there, and then another one maybe in front of the heart, way up in that little corner. Yep, right there. And then again on the left side, there's 3 sort of hard to see arrows pointing out the little dots over there. So there are multiple, I would actually say innumerable, once you start counting, right? Once I get over 10 or 12, I'm like, okay, I don't know how many there are. There's a whole lot of little tiny presumed metastatic deposits. And I am told by my chest colleagues that thyroid cancer in particular can be minuscule in the chest.
Thank you, Mary. Next slide.
Okay, so the pathology on the excised lymph node, here at low magnification, you can see the entire node, which I think is bivalved here, is replaced by this tumor. And then the next slide is going to show at a little higher magnification. Even at this magnification, we can see it's papillary thyroid carcinoma, as everybody suspected. It looks like a classic type of papillary carcinoma in that it has a papillary architecture with a little bit of follicular pattern. And the nuclei, they're all kind of pale which reflects the classic PTC like nuclear features, pallor, grooves, they're probably inclusions. So this looks very good for the papillary thyroid carcinoma that we all suspected.
And Lucy, can I just ask for I mean, I know this never happens in MD Anderson. This is always an outside hospital. Why an excisional biopsy other than finding laceration? I mean, we do.
I think,
Yeah.
yeah, I think this surgeon was thinking of other possibilities like lymphoma and took this approach because of that concern. And it was a bulkier type of presentation of the neck. So I think they just wanted a quick answer. But yeah, that's a great question. And certainly we would normally try FNA, but we're lucky in that we're a referral center and we're already usually have a suspicion of the diagnosis. And before we move on to the next slide, I guess a question to the group is when we would consider molecular testing. So that this biopsy comes back as papillary thyroid cancer. We already know she's stage 2. I know in the ideal world, we would love to have all this information up front, but when are you normally trying to do this in your patients that are stage 2?
So a couple of things. I'll answer the question, but I also wanted to make a point just in general. So the answer in terms of molecular testing is it depends on conversation with the surgeon and whether this is resectable disease up front. If it's resectable with standard operative morbidity, then I don't think that there's necessary benefit to preoperative molecular testing, and we can wait until we've got the pathology specimen. If they say this is inoperable disease, or I'm going to have to sacrifice the recurrent nerve, and probably make, this is a big bulky gland with a lot of bulky lymphadenopathy, then there may be a role for molecular testing to offer neoadjuvant therapy.
Sorry.
Yeah, that's okay.
If I could just say something, we're kind of jumping the gun on molecular because most pathologists will routinely do immunochemistry for BRAF. It's a cheap, fast test. We do that on every single papillary cancer as well as NIFP. If you did BRAF on this, it's positive, great. If it's negative, and then we would also do a RAS immunostain, and if that were negative, that might prompt you to do molecular testing, but you don't have to necessarily jump to molecular. You can do a couple of cheap immunostains, RAS and BRAF.
True, Bill. I don't think this is RAS disease from the pathology. And the BRAF in an 11-year-old BRAF is very, very unlikely. But certainly you're absolutely right. The other point I wanted to make just before we move on, since we are trying to emphasize the pediatric nature of this tumor board, is we don't necessarily, this is a patient with M1 disease with pulmonary mets, and we don't immediately hit the panic button in these situations, and there's still a role for reassuring the patient. We know this patient's prognosis in general with pulmonary disease is still highly favorable, and I think that's an important distinction with many M1 patients who are 60 or 70 years old. And wanted to emphasize that component of pediatric thyroid cancer is different.
Jonathan, let me follow up because I'm still chasing this molecular thing. I mean, from Mary raised the potential this might be diffuse sclerosing, right? From what the ultrasound looked like. So we're thinking this might be a fusion, right? So in this situation, if we get down this pathway, unlikely to be BRAF, unlikely to be RAS. If it's a fusion, then maybe there's something we can do to help kin with the surgery. So I mean, that's how I read this in adults. And the kids, you feel the same way and sort of likely a fusion here?
Yeah, I think that's true. This is based on the imaging. This is could be, if it was an older patient, could be BRAF diffusely infiltrative classical PTC, but certainly diffuse sclerosing becomes more and more common as the patients get younger, and the behavior of this would be consistent with either, and fusion is going to be very likely in the diffuse sclerosing patients, and often targetable.
Ken, and then back to Lucy. Ken?
Yeah. So a couple few things. One is that back to the concern about lymphoma in kids. In the past, the teaching has been that you need a lot of tissue to run flow and other tests to diagnose lymphoma. But nowadays, they can do that on a very small amount of tissue. They can do it from an FNA. So if they have a concern for lymphoma, they don't need to take the lymph node out. they can just do a needle anyway. Secondly, Lucy, do we know that the vocal cords are working on both sides? Was that assessed prior as well? Because if one of the cords is out, then we are running a little bit of a concern for invasiveness of this disease into the structures.
Yes, great question. So she does come to MD Anderson, and we do assess this. And yes, it does. They are both functioning. I think because of the concern, though, with her being a singer and just having potential neurovascular involvement, that this question comes about doing molecular testing preoperatively to see if we can help reduce the size of the tumor and help optimize the outcomes of the surgery. So that leads to our next slide, actually. Yes, so we evaluate her after her diagnosis of PTC. Her baseline labs come back with a TG of 146, negative antibodies. And then, yes, we do get the molecular testing, which reveals an ETV6 and CHEK3 fusion. And again, mainly because there was concern of potential involvement of these neurovascular structures, which is hard to show in the few pictures that we have. So next slide. Yes, so she does get offered larotrectinib, and this is started, and we ended up restaging her about 3 months later. So if Mary can comment on any changes that are seen.
Pause for me just a minute, Lucy. Both Ken and Andy, tell me when we're not going to do larotrectinib, right? This is a neoadjuvant thing, right? So the idea here is which cases do you think about it? Because we're going to see a lot of these mutations, so when do we not think about this? Because it seems like now everybody's throwing this in the water, that sort of stuff. Maybe Andy go first, and then you guys help me out on this.
Sure. We can go together because it really is a discussion with the surgeon. So if there's, visceral involvement, if there's no neural involvement, so there's something that increases the potential morbidity of the surgery, then it's a good opportunity to take advantage of these drugs now that we have in clinical practice. Larotrectinib is approved down to newborns, and selpercatinib's down to 2-year-olds. So we have a great opportunity to use them, to your point, Mike, but there really is a selection. So we've had patients referred to our center where they were thinking about neoadjuvant therapy, and Ken reviewed all the images and said, this is a patient that I can safely take to the OR. And we did not do neoadjuvant therapy, and some that we have. So clinically, I rely on Ken's judgment, and it really involves adequate imaging and assessment of the vocal cords to make sure we're making good decisions, not just using a drug that's available.
I mean, to expound upon that, that cross-section imaging is really important, especially looking at the tracheal wall. Is there evidence of invasion in there? The great vessels, are they completely more than 180 degree encapsulated or completely encapsulated? Do we have, like on that second, the middle, the more that CT scan there, you can actually see the lobe going behind the trachea and almost retroesophageal. That's really getting concerning for that tracheoesophageal groove involvement. And as you said, this is a singer, and we would really be worried that you're going to have to dissect that nerve out and put it at significant risk. But if we don't see that going back into that tracheoesophageal groove, not around into the trachea, not around the vessels, even if it's big, we usually can get around it.
Yeah, Jonathan, any differences or thoughts there?
No, I agree, Tyler. I think this is a surgical decision making in combination. We have, like Andy said, we have the drugs, but we need to know when we should be using them.
Awesome. Mary,
when
tell
we
us
do
what we're
use
looking at.
them, one of the other problems we sometimes will get into is that desmoplastic changes after you've used them, and so that also can complicate the surgery as well. It makes it more sticky, can make that dissection in that tracheoesophageal groove a little sticky as well. So we do have to keep that in mind as well. And then we also have to say, how long do you want to use them before we actually go in? And if there's involvement of the trachea, you have to be careful also as the tumor regresses, you don't get a hole. And then you end up with a big problem because there's a hole in the trachea.
Yeah, so certainly not automatic when we see these guys with lots of lymph nodes, because you're used to doing this in kids anyway. So a thought process. Mary, tell us what we're looking at, and then back to you, Lucy.
Yeah, I'll just say that that's one of our jobs in ultrasound. If people are paying, or on top of things, is to look at not just the surface of the gland to see if there's any invasion there, but to look at the trachea, to look at the carotid, to look at the jugular, to look how far deep into that tracheoesophageal groove the mass goes. Again, because that's where the recurrent laryngeal nerve lives. So on these CT scans, I assume they're both done the same day, but I think the easiest place to look at is on that right side anterior to the jugular vein, where we were looking at the subclavian vein and the jugular vein, and there's that lymph node. So again, okay, let's start medial. So start with the trachea. The black circle's the trachea with a little pressure on it in the back from it's not exactly round, right? The back of the right lobe is compressing a little bit on the trachea. Then you hit the common carotid artery, then the jugular vein, and then the next one out, that's the lymph node that we had looked at before. So although maybe that one got removed. So the big one got taken out. So this is perhaps one of those medium ones that we had seen before. It looks smaller. It looks like there's less adenopathy in the neck in comparison to the prior, but it's not completely gone, right? There are still lymph nodes on both sides. There's a couple more there on the left side.
Excellent. And I will just add, I agree with the discussion. This did involve a lengthy discussion with the surgeon and with the family before we started larotrectinib. Lots of risk versus benefit discussion before we started. And ultimately, yes, because she was a singer and the risks to her vocal cords, we decided to proceed with the larotrectinib. So on the next slide, we'll see her response at 6 months, and she actually had to get it without contrast. So it's that last image on the right.
Yeah, so the third CT over. Things are a little bit smaller, right? We'll go, trachea, carotid, jugular, and then there's that lymph node again. So that's a little bit, I think that's smaller, right? It's hard to know in one plane, but it looks a little bit flatter. It certainly hasn't gone away, right? It hasn't been, oh my gosh, everything is gone, this is fabulous. But we're seeing a little bit of change. There's another lymph node on the left side that sits right on top of the subclavian vein, sort of right behind the clavicle. So, sorry, go over to the left, other side. Yep. Right, next one in. That one, yep, that one, if you go back, that one is probably a little bit smaller as well over time. So you're seeing some response, but not a crazy, oh my gosh, everything's gone response.
Right. And I'll add that she has been tolerating drug throughout this time. She had just grade 1 transaminitis, but otherwise had been doing well. We felt at this time, because it had reached, somewhat stability and probably maximal response on the drug after 6 months, we decided to offer surgery at this time point. So at the next slide, you can see the surgery results. So we did hold larotrectinib prior to surgery. She got a total thyroidectomy plus bilateral central and bilateral lateral neck dissection. She did end up requiring microdissection of the bilateral recurrent laryngeal nerves, as well as the right spinal accessory nerve and right retropharyngeal dissection. But she did very well post-surgery, and she did require drains, had some transient hypocalcemia, but her bilateral recurrent laryngeal nerves did stimulate well.
So on the pathology at low magnification, the lobe has a very irregular, abnormal appearance to it, with sort of areas of a little bit of fibrosis. It's hard to tell at this magnification if this is all tumor, but I'm suspecting it is. And I think the dot up near the top of this lobe probably represents a suspicion for a little bit of microscopic extrathyroidal extension. It's kind of hard to tell at this low mag, but I think that's what is indicated there. And then the next slide is kind of interesting. It's actually a little bit difficult to exactly tell what is going on with this follicular pattern disease. It looks somewhat a little bit sort of atrophic, and it's a follicular pattern. It's different from the pattern of tumor that we actually saw in this supraclavicular lymph node. There's a little bit more pallor in the middle part, but I'm wondering if this is like a treatment effect on the tumor that's, we're not seeing all of that papillary architecture, et cetera. So I think this might be treatment effect.
That's fascinating.
Yeah, interesting.
And it should be, because we see treatment effect in anaplastics that the BRAF positive ones that get dab trimmed. So that's interesting, Bill.
Yeah.
Thank you, Bill. Next slide. So it did come back as papillary thyroid cancer, diffusely infiltrating, and Bill was right. There was microscopic extracellular extension. 30 of the 122 lymph nodes were involved, the largest being 2 centimeters in the right lateral neck. So a question for the group is, she's already gone on drug preoperatively. Would we consider restarting this prior to her first dose of radioactive iodine? Because this is someone with pulmonary mets, high risk that we usually would be offering radioactive iodine to.
I think we don't know, Lucy. I think classic PTC tends to, it's not BRAF driven, it's fusion driven, so it tends to be iodine avid. We could look at a pre-treatment scan to see what it looks like and if she's got a lot of uptake, but might be appropriate for a clinical trial as well to look at the role of systemic therapy in enhancing iodine avidity.
It'd be interesting to see a repeat chest CT too. She may have complete regression, right?
Yeah.
Yes, I actually didn't show this, but yes, they did actually regress, and we could not see them on chest CT while she was on drug.
I guess the question is the iodine being used then as adjuvant therapy, not as treatment of distant mets?
Right. I would still, even though they're so subtle, we always know they can come back.
Yeah.
And that was my concern with this patient. So I know we're wrapping up. So I'm going to try to go a little more quickly through the next couple slides. Go to the next one. So we did elect to restart lirotrectinib. And again, that's an interesting question of whether our patients can benefit, because a lot of our patients don't get complete response to radioactive iodine. So because of these lower cure rates, we're wondering if this is a potential better approach. And again, it has to be better studied. And we know that radioactive iodine is still the standard of care approach. But the next slide, you can see that her diagnostic scan.
So Lucy, I can interpret this. Yeah, just to comment, with the radioiodine protocols, we do everything we can to improve the uptake into the thyroid cancer, because it's not as good as thyroid tissue. So we put them on low iodine diet for 1 to 2 weeks, and then we do TSH stimulation withdrawal. And so any other method we could think of that could improve the radioiodine efficacy would be welcome, I think. So we need to look more into this area. This is an iodine 123 diagnostic scan. It's got thyrogen stimulation, and I think there's very faint uptake in the neck. And looking in the lungs, I'm a little underwhelmed. Iodine 123 has very favorable imaging characteristics of 159 keV gamma emission and a 13-hour half-life, but it still remains insensitive compared to the post-therapy scan. So you're going to need to go ahead with therapy to really know if this is iodine avid or non-iodine avid.
Thank you. And yes, I'll add the TG was 36. This had been after 6 months of treatment, but she had actually run out of the lirotrectinib a few days beforehand. Agree that the sensitivity of the diagnostic scan is not as great as the post-treatment scan. So yes, you can see the post-treatment scan.
Yeah, so you gave 100 millicuries, which is a very good dose for an 11-year-old, and I'm assuming you do body weight adjustments for that. And you can now see really intense radioiodine uptake in bilateral neck, and some of that could be remnant tissue, but there would also be concern for residual iodine avid cervical disease. And now we're seeing multifocal radioiodine uptake in both lung fields, and probably more than what was disclosed on the initial chest CT. And that's one of the things with the radioiodine being very sensitive for very small microscopic disease as well. So this looks like she will respond really nicely.
Excellent. And this is our last slide. So at her last follow-up, a few months ago, she was doing well. Her TG was 2.8 with a TSH of 1. We did intensify her levothyroxine. Her ultrasound CT of the neck was out without recurrence. But her CT chest did show these multiple tiny little lung nodules. So family, was hopeful that these would remain. It disappeared on imaging, but we did reassure them about prognosis. And coming back to what Jonathan said, we know that regardless, prognosis is excellent in this population.
Yeah, and Jonathan, yeah, we'll stop there. You can go ahead and take the slides down, Andy. Jonathan, if this is my 15-year-old child, I'm freaking out. She's got lung mets, that sort of stuff. When you have that discussion with the family, how do you frame that, that discussion with them?
Yeah, I start the discussion the first time I meet them, or at least when I know that there's lung disease, and I say, we're going to treat this. I'm going to be with you for this journey. It's going to be a long journey. You're going to be okay. We're not aiming to cure you of this disease, and we are endocrinologists. We're used to treat diseases we can't cure. We don't cure diabetes. We don't cure Hashimoto thyroiditis. And I think that's a shift in mentality that we as treating physicians need to adopt. Say you're going to be fine, and we're going to treat this like we treat other chronic diseases. Make sure you're stable, keep an eye on it. But I think setting those expectations early on is helpful in establishing that.
Absolutely. Andrew, I got about 1 minute, and there was one question. When would you think about a second dose radioactive iodine in this setting, Andy?
If you see structural disease that's significant and plateaued as far as therapy, and there was a response to therapy on the first one, or progression.
Gotcha.
Progression's an easy one that we would all think about a second dose.
But
Structural
on
on
this
CT.
one, we're probably sitting back and watching for a year or 2 or 3 in
Correct.
all likelihood, or longer, right? Would be
Correct.
our general expectations. All right. Andy and Lucy, you guys stuck the landing. We are 1 minute. I asked you to be done 1 minute, despite Jonathan and Ken. I mean, you did good. We're cruising there. Thank you very much. These are fascinating cases for us to learn, and really appreciate all the panel. My last commercial is the Voices of Wisdom podcast. I'm totally biased, but these are incredible snippets of practical clinical advice that if you can't fall asleep at night, put one of those on. They'll put you right to sleep, and you can use mine. It'll put you to sleep. But these are fantastic things to listen to. Thanks again to the panelists for all the cases, all the work. Great job. Here's the upcoming meetings coming up, and we'll wish everybody the best. Thanks, team.